Hello, friends. Welcome to this special episode of AMR Dialogues. These dialogues are hosted by CNS and Global AMR Media Alliance, or GAMA as we call it. AMR Dialogues feature conversations with AMR leaders from around the world, including AMR survivors, AMR scientists and researchers, and others engaged in raising awareness about antimicrobial resistance, which is one of the top global public health threats these days. Our guest for today is Dr. Sangeeta Sharma, Professor and Head, Department of Neuropsychopharmacology, Institute of Human Behavior and Allied Sciences, New Delhi, and President of Delhi Society for Promotion of Rational Use of Drugs. Welcome, ma'am. We are indeed honored to have you with us today. Sangeeta ji, early and accurate diagnosis of any disease is an important first step towards right treatment and for stopping misuse or overuse of medicines. Your work on diagnostic stewardship is so critical. But diagnostic stewardship is also little known. So can you please elaborate on the importance of diagnostic stewardship for our listeners? Over to you.
Thank you, Shobhaji, for arranging this dialogue with the diverse group of people who are interested. I think the topic is just right. And you've said our work on diagnostic stewardship is very critical. As you know, AMR is a major growing public health problem issue, and most of it is considered as silent or slow. People are not able to appreciate the impact of this AMR on our health, on our environment, our productivity, economics. It has tremendous impact on this. So with this, right now, we've been working on this for last 25 years or more on this. And for last 4 or 5 years, we've been focusing on the stewardship activities because we started with the antimicrobial stewardship program in the country. We've arranged several batches with the clinicians, microbiologists, pharmacologists as to what they understand, what are the core principles, why is this needed, etc., etc. Now, while we were doing these programs with them, we had been having interactions with the participants. And then we realized that most of the antimicrobial use that is happening is because of the diagnostic uncertainties. Because many times, or very often, it just happened that just in case if it happens to be a bacterial infection, so I must prescribe some antibiotic for it. So that's where, we started thinking of it, should we work on this aspect? If clinicians are able to make a diagnosis first, and then the treatment can be set accordingly. So basically, you can consider that the correct diagnosis is the foundation for initiating treatment. And that is true for all illnesses, particularly so for infections, because these infections are needed to be treated with antibiotics. And these antibiotics are directed towards the pathogen, unlike other drugs which are directed towards the disease, whatever is the abnormality or imbalance has happened in the body. But here antibiotics are to work on the pathogen. So that's where need for arriving at a diagnosis comes in. But at the same time, if you want to arrive at a diagnosis here, for microbiological testing here for infectious diseases, you need to have precise tests which are reliable, sensitive results. And even if the test is reliable, sensitive, you need to collect samples. There is a particular process of collection of specimen, transporting these and reporting, retrieval of these, then interpreting these and correlating with the patient's condition. These are all the other steps involved in optimizing the use of this microbiological testing. So when we were working with the for the AMS program, that we realized, and even our own experience of working in the hospitals or visiting various rural and other different levels of health facilities, we found that very often specimen, how do you draw sample, which is the most appropriate sample, how do you draw it, how do you store it, how do you transport it, before it goes to microbiological testing. There are many things which go wrong at this pre-analytic stage itself. And with microbiological testing, one thing is very clear: if the sample is not appropriate, if the sample is not stored or transported properly to a lab, we will not be able to get good results out of this microbiological testing. It, for example, if the urine sample, when we send it for testing, we may get nerve growth, or we may get some contaminants growing on this urine sample because the urine sample wasn't stored properly or transported. Now, just because we have grown something in the urine culture, the doctor may be tempted to use antibiotics. So that's where it becomes irrational or inappropriate. So with this thing in mind, we thought of this diagnostic stewardship program, and any AMS, antimicrobial stewardship programs, they cannot achieve their objective, or in other words, they rely heavily on the diagnostics support for accurate and timely diagnosis. So in a way, if you say these diagnostics stewardship is all about processes of ordering, performing, reporting of diagnostic tests to improve the diagnosis for the treatment of infection and other conditions. But you cannot achieve this in isolation. This is part of the bigger, overall, if you call this antimicrobial stewardship is a broad strategy, diagnostics stewardship becomes a part of it, and that helps you in making the right testing for the right patient at the right time, so that you take appropriate decisions about management of these patients. But what happens very often is, many people, when we say diagnostic stewardship, they think it is to do only with the microbiological testing. It is more than that. Microbiological testing is part of it. Interpretation of these reports, and then treating the patient, then feeding this information back to the microbiology lab is very important for effective management of these patients. Now we know, we as soon as we get these patients, when they are very sick, they are put on empirical treatment. Empirical means just on basis of your clinical judgment, that you start with some antibiotic. But for stewardship, for the optimization of antibiotic use, we must make it definitive or targeted as soon as possible, because this empirical is broad spectrum, antibiotic which acts on many pathogens at the same time. So it not only affects the pathogen which is causing infection here, but it can also impact your normal flora. Our body is inhabited by normal flora, and they have good bacteria which are needed for digestion, assimilation, manufacture of some nutrition. So they are protective as well. But when we use broad spectrum antibiotics, our protective normal flora also gets damaged. So that's where we are also worried about, not only that the germs will develop resistance, they will devise mechanisms to defend themselves. and they keep surviving, growing, multiplying, even in the presence of these antibiotics. And that's where we call that resistance has developed, because it is the pathogen which has stopped responding to these antibiotics. Now, there is one misconception also here amongst many groups of people, even the doctors. Many people think that something goes wrong with the body. That is why the response is not there. So it's not that the human body is going wrong here. It is the pathogen's defensive mechanism which makes this pathogen help surviving even in the presence of these antibiotics. So I think one message I would like to give everyone is that it is the pathogen which develops this defense mechanism, and this is a natural phenomena. This is nothing new. This is a biological, natural phenomena inherent in nature. Because, and I always say, germs are smarter than human beings. They have always remained one step ahead of human beings. When we devised these antibiotics in 1940, the Alexander Fleming, when it was marketed, at that time itself, they observed that this resistance will develop. This is a natural phenomena. We cannot stop this phenomena. All we can do is to slow down this process. So, coming back to the empirical and the targeted, your question about this, as soon as you make a diagnosis, you can switch antibiotics which were broad spectrum, because at that time you did not know what is the germ which is causing this illness here. Once you know that this is the pathogen, and then you can prescribe antimicrobials according to its sensitivity pattern. So you can make it more definitive. So other collateral damage on the body is minimized by making a good diagnosis here. So that's one reason, because most of the antimicrobial use is driven by diagnostic uncertainties. So, and we are using these tests. These are available. We have made a tremendous progress, right from, basic gram staining to molecular testing. Rapid diagnostics are also available. Point of care testings are also available. But at the same time, we are also worried about overuse of these diagnostics. If we don't use them at the right time for the right patient, it can again cost the patient, and it may not give you the right kind of results which you are expecting, and which will help you in tailoring the antimicrobial prescribing for these patients. So this diagnostic, that's where we started. We started in 2022. At that time, COVID was ongoing. So we went online. It didn't stop us. And we were very, very, surprised to see the response. More than 450 clinicians participated in the program. Because, nurses and other staff also have a role in optimizing the antimicrobial use. So we also devised one program for the nurses and laboratory technicians, because storage, transport, then testing, all this is the domain of the laboratory professionals. But nurses, overlooking all these aspects in the ward, are directly overseeing these activities. So we thought that they should also be involved in it. So we developed a program for that. So, this it is very essential that all of us, clinicians, nurses, lab people, pharmacy, work in align sync with each other. Because if any of the steps goes wrong, we will not get the desired results. So that is why we planned a holistic program. So first year we did all online. Nurses, around 1,600 nurses participated in this. So then many people said online programs have their own limitations, and we agree with it. It was a blessing in disguise at that time. So we started, last year we started with the face-to-face programs. So far we have had June 7th and 8th in Delhi was the 7th program. And the this is one of our flagship programs that we developed, which included pre-analytic interpretation part. And the beauty of the program is that we organized a fora here where clinicians and the microbiologists came together. You will not find such forums. Either you will find that all microbiologists are having their programs, or all clinicians are having their programs. But both attending at the same time and looking at the same problem was not a very common phenomena or fora. So we brought them together here because each one of them have their own problems. When they are testing microbiological, doing tests, they have their own issues or problems or requirements which need to be met by the clinicians. And at the same time, clinician may sometimes feel that I'm been sending the samples to the lab, and this laboratory is not giving me credible reports. Either it is saying no growth, or the result is coming later, or this didn't help me, or the colonizer or contaminant was there, so I couldn't make a correct diagnosis. So each one of them had their issues, so we brought them together. So we had case-based scenario discussions in these programs. This is one of the thing that we introduced, so that, and we look at the patient from both microbiologist point of view as well as the clinician's point of view. Because many a times, many people, when we said, okay, we are doing this diagnostic stewardship, they thought that this is to do with only microbiology. So we wanted to emphasize that you have to come together, sit together, and look at it from the same different point of view and arrive at a consensus. So that was our experience about diagnostic stewardship. And we feel very strongly. I now today, after doing 7 batches, around 1,000 people, clinicians attending this is the roadway to the antimicrobial stewardship. Otherwise, many people used to say, where is the irrationality? It is the patient which is very important for me. Individual patient which has come to me is very important for me. I don't know, if AMR develops or what is happening to the magnitude and etc. etc. So, but when we, do these programs, we emphasized on them that antimicrobials are a different class of medicines. They are not same as paracetamol or antihypertensive or diabetic medicines. Here, individual use of antimicrobial for an individual patient has a impact on the society in terms of AMR, because it is not that AMR is going to restrict it to that individual patient only. It's going to spread in the communities, in the hospitals, and then we see the consequences of these. So that's how I think we place this diagnostic stewardship here, and we talked about practical aspects of collecting samples. Then one of the very important, one very simple intervention, if everyone can do, is, one simple step, that you start taking samples before administering first dose of antimicrobial. That itself will change the picture. Many times, because the patient is very sick, nurses are not aware. So, it may just happen, antimicrobials are prescribed, administered, and the samples are drawn later. So all of us know, if in this kind of a situation, the results may not be optimum. So diagnostic stewardship talks about the gaps, and unfortunately, when we did this, looked at the feedback, pre and post test responses from the participants, we found that some of the very basic requirements of collecting samples, knowledge deficits were there. For example, particularly about blood culture, particularly about how to send a urine culture. It sounds very simple, but we found there were deficits there. And of course, then there are other practices which may hamper or may affect the outcome.
Thank you for simplifying this, and rightly so. correct diagnosis and timely diagnosis, both are very important. That, as you said, they are the first step. Now, once correct diagnosis has been made early and accurately, what's next? Now comes the antimicrobial stewardship.
Yes,
Yes. So,
that's where,
yeah,
that's where I meant
yeah.
that diagnostic stewardship is the way to antimicrobial
Yes,
stewardship.
yes,
Once
yes,
you have a diagnosis made, then now our role is antimicrobial stewardship role comes here, where we can optimize the use. This optimization can happen in the form of that you switch from broader spectrum antibiotics to narrower spectrum antibiotics, so that collateral damage is less. Or when maybe when the patient was very sick, critical, you may have started with 2 or 3 antimicrobials, just on the basis of your clinical judgment. Now, once you have the diagnosis, you have the pathogen identified with you, you can narrow down, you can reduce some of these antibiotics which are not needed, no longer needed for the management of the patient. That's one way of making it more definitive, targeted therapy. Then maybe there are situations that you may switch to from IV parenteral antimicrobials to oral ones. That is considered to be convenient, not only convenient for the patient, but is also more safer, lesser infections happen, because whenever you have central lines in place, these also lines may introduce infection in the patient. So switching from IV to oral could be one. Then if you cannot, sometimes you are able to do it, if you still cannot do that, then you can look at the duration of antibiotics. Duration, early now the experts are saying, or there are enough evidence now, it should be shorter duration antimicrobials. What happens in clinical practices, many times these antibiotics are started, but since there is no review taken of these antibiotics, or correlation or interpretation with the reports, if not done, there is a chance that the patient may continue to get this empirical broad spectrum antibiotics for longer duration, so more damage would be there. So if you have these stewardship interventions or actions at the ground level in place, you can see to it that the duration of antibiotic, if this can be successfully reduced, so that it will help you in managing the individual patient, as well as saving these antibiotics for future generation by slowing down this antimicrobial resistance. One thing more, use of these antimicrobials is the key driver. I always say this: if you use it, AMR resistance, a natural phenomena, is bound to happen. More you use it, you will accelerate this phenomena of AMR. So if you are not able to reduce or stop this, at least reduce this so that AMR is also reduced. One more thing, empirical, I always say, is like a open sword. If it has, it protects you, but it can harm you as well. But if you can work with a knife or a needle, that's always better. So that's what I mean, switching from empirical to narrower spectrum. That if you need this sword, only reserve this only for situations where there is a dire need for it, but don't use it, take it out on smallest infections. I've seen many people, simple one single abscess which can be managed easily with incision and drainage, but antibiotics, and that too a broader one, the sword type of a antibiotic, is taken out. Simply managing wounds with the debridement or simple cleaning, we try to do it with the antibiotics. I've seen many people, I don't know why and how this has come in, uh, antimicrobials being used after delivery, normal vaginal delivery, which is again a natural phenomena, a physiological phenomena. Why should, anyone will get infection during birthing? But antibiotics are used for that.
Yes. What about how do we know, supposing the pathogen there is resistant to that some particular antibiotic which is being administered? So do we do drug resistance profiling or what is the way out there?
See, when we say microbiological testing, we're trying to do two things.
Both.
One
Okay.
is to do the we want to identify what is the pathogen or germ which is
Yes.
causing infection. Second is what is the sensitivity profile of this pathogen.
Okay.
This pathogen will, whether it will respond to X, Y, or Z antibiotic or not. So they put up, this is called culture and sensitivity testing. They put up this test in the lab, and then they will come up. You must have seen in the reports, they'll write S or R there. S
Yes.
is for sensitive, that
Sensitive.
means it will respond to this antibiotic, and R is for that this is
Resistant.
not laboratory setting, they have tested, and according to them, this is not going to respond to this particular antimicrobial. So this is where the interpretation also comes in for the clinician. They need to interpret this report and tailor the therapy according to this report. Now, what happens is, many times, many labs, if they are not careful about the stewardship or the diagnostic things, they'll put up, let's say, 15 or 20 antimicrobials testing for this sensitivity. This may include higher end antibiotics also. Or the patient is just simple urinary tract infection, otherwise healthy, but simple urinary infection. So you don't need higher end antibiotic for this patient. So there is no need to put up test and report this higher end piperacillin, imipenem like drugs in the sensitivity panel for these drugs. So that's where also we, in the diagnostic stewardship, we talk about this, that tailor it according to the situation, so that improper use is discouraged. First line always that we practice is that give oral antibiotics, simple ones, which do not have many adverse effect. First, they should be tried. If patient does not respond, then of course you can escalate it depending on the response to the ones which are coming out as a sensitive pattern. So we tell people to go for cascade reporting. First line antibiotics, that you talk about needles and knives here.
Yes.
Reserve these swords for the second level reporting. So that's what we call selective reporting or cascade reporting. That's one way to discourage the use of higher end antibiotics for simpler infections.
So right diagnosis at the right time and right treatment, can go a long way to address this issue of AMR. But will this also help reduce the spread of infection? Or do we need to do more on infection prevention and control?
Yes, definitely. With antibiotic, both overuse and underuse are problems. Overuse, I have already told you how it accelerates antimicrobial resistance. But at the same time, underuse, when I'm talking about those patients who need these antibiotics, but they don't get it either because of the accessibility, availability issue, or maybe the diagnosis wasn't made due to some reason. If they don't have access to so that means they will be infectious for longer period. So if you remain infectious for a longer period, you tend to spread this infection to more people, more and more people. So that is what we keep saying. Underuse and overuse both are a problem. But in India, certainly in metros there is no problem of availability, but there are areas in the country who still do not have access to even simple antibiotics, first line simple antibiotics. So we need to work both on access issues as well as the curbing the overuse of these antibiotics. Now, coming down to this is one part of the antibiotics. Now, we are all aware. There is a dictum: prevention is better than cure. So we need to work more on the prevention part, so that infections do not happen. Because I always, every time I see these patients, I feel nature has always been in control, and we are not in fight with the nature. We have to live in equilibrium here with nature. So since nature is in control, particularly I think our generation and the younger generation have witnessed this COVID pandemic, how nature is in control. COVID came as a tsunami to us. We didn't know what we are dealing with. We didn't know what it is in the first, wave. And then when we came to know about this COVID infection, that this is viral infection, and we came out with the diagnostics also, but we still saw that many people were using antibiotics
Yes.
just in case that this is a bacterial infection, or just in case that this is a secondary super added infection over and above COVID. Or of course severe COVID, moderate to severe COVID patients, certainly they were given antibiotic, they were admitted, that was justified. But for mild and COVID, still people gave it. And I just now mentioned to you about normal delivery patients getting antibiotic. So why am I telling you this is because we feel that antibiotics are being used as a shortcut to spend infection prevention and control activities, antimicrobial stewardship, diagnostic stewardship. All these requires active inputs here. Whereas infection control is the basic thing if we want to control infections. Otherwise, nature will take control. We keep hearing about these outbreaks. Diphtheria is rising, measles is rising. We need to think about other forms of treatment, vaccination, prevention part, promotive part of this. And when infection happens in one patient or in one community, we need to look at how do we control transmission to other people or in the community. So definitely, without infection prevention and control, you cannot say that you are having stewardship activity. So a stewardship is needed, and all these three need to be integrated here. If you say I have IPC, I have AMS program in my hospital, I don't bother about the diagnostic. You cannot do anything. You have AMS, but don't have IPC. Again, you cannot achieve the desired goals here. Although COVID has sensitized many of us on this IPC a lot, but I see again a change here. During COVID, we were so worried about the hand hygiene. We were washing it. I think we were overdoing it during COVID times. But now again, hand hygiene has gone down. So to me, to some extent, this appears like a behavioral issue. And this needs to be integrated. Unless you do this, see, even in communities you have a lot of sanitation issues. There is garbage is collecting, and waste disposal is not happening properly, water hygiene is not good, you don't have access to potable drinking water. What kind of infection control are we talking about? All this needs to be integrated.
You are very right, Sangeeta ji, because even during COVID times when we were told wash your hands as often as possible. And I was wondering about homes, many such homes where they have not enough drinking water. They don't have enough. How much water will they spend? For them, it is wasting water in washing their hands when they don't have enough to drink. So we have to look at the other social inequities also, I think, as without addressing them, we just cannot concentrate on one or two aspects. That is important.
Very true. Even listening to news today, these days, there are water crises going on in Delhi. What kind of sanitation or hygiene are we talking about when they have basic access is not there.
Yes, yes.
You
Right.
have 2 liters of water available, and how do you do it? And plus this heat wave,
Yes.
this warmer temperature is promoting the growth and spread of infections, waterborne infections. So all these are connected.
Yes.
You cannot look at this in isolation.
Isolation. Right. So are there any challenges? You have been working in this field for so long. Are there any challenges, or what are the main challenges in implementing IPC, DC, and AMS, sorry, DS and AMS in combating AMR at the ground level? What
Yeah.
are some of the challenges which you have
Very, very
encountered?
difficult question, but let me try, because we've been working on the ground
Yes.
with these. AMR, let's say, is a multi-stakeholder, multidisciplinary, multi-sectoral problem. So it's a very, very complex problem. There are many actors, players here. Human sector is there. Then there is a non-human sector. Use of these antibiotics happens in animal sector, aquaculture, agriculture, environment, waste disposal. So there are many actors. Even, okay, if you forget about these, you need to talk to all of these actors, because each one of them is contributing to AMR in one way or the other. So even if you limit your activities to human sector, within human sector there are so many people who are involved in the management of the patient: doctors, nurses, pharmacists, administration, hospital people, and even within human clinician community, you have so many specialities. So each one of them is using these antibiotics. So the denominator here, which needs to be trained or sensitized or empowered, is huge here. So that's the first immediate thing. And then you need resources, for capacity building. Now, we've been organizing this program, and we find, although the laboratory people like microbiologists, pharmacologists, other people, nurses, they are quite open and they will come and attend this. But clinicians, even if they want to attend to these programs, timing, finding a suitable time for their upgradation, for their skill building, becomes a challenge, because they have their own very demanding clinical commitments. So many times they override these programs. So human resources are needed, and to do these programs or sustain this. Many times these orders from the government, for example, National Medical Commission, they have said that all people in the tertiary care hospital colleges should be trained. This antimicrobial stewardship committee people should be trained on these aspects. So that kind of things enables us. They come forward for these credit hours help, uh, but finding time for them. We've been, innovating with the suitable time. Is it a working day which works best, or is it a weekend, or is it 1 day program, or a 2 day program? So that's one of the biggest challenge that we face. And of course, you need to sustain this. We being the non-government organization, non-profit making organization, find it difficult to sustain such activities. But certainly, the awareness and the demand for this is increasing, and I hope it will change this situation, and people will become more, they will themselves come and demand for these things.
We understand, Sangeeta ji, that India's 2017 National Action Plan to combat AMR is undergoing revision. So, can you let us know if the new updated version will include all these which you have spoken about today at length?
Yeah,
DLS,
definitely. Yeah,
yes.
definitely. Our India's National Action Plan was enacted in 2017.
Yes.
This was it aligning with the Global Action Plan on AMR. So we have included all those strategic priorities in the 17 itself, but we went ahead. We added one more strategy here, leadership. Amongst the five leadership that are there in even in the global agenda, the first one is about the awareness of this problem amongst all stakeholders, not only public but also prescriber, pharmacists, all sectors. Then second is strengthening laboratory uh, capacity here, uh, because that is very much essential. You cannot tackle a problem of AMR unless you measure it. And that is true for any problem. Unless you measure it, measure the size of the magnitude of the problem, you cannot address the problem. So same is here. So you need surveillance of antimicrobial resistance. What is the extent? Because many times when we talk to the people who are using these antimicrobials, we need to convince them, go to them with data. So that surveillance data is required. So this is how the problem is rising, and this is how we are losing our patients to these drug-resistant infection. Then second is that you go back to them with the antimicrobial use data. So both antimicrobial use surveillance is required and AMR surveillance is required. So, many times when we, go and give the, talk about this, many people say, we don't prescribe any antibiotic. It is someone else, or it is that corporate hospital, or it is that particular practice, it happens. But when we say that, okay, we collected this data from your community or from your hospital, so when they see alarming uses, they get convinced. So laboratory second is about that. Third is IPC, infection prevention and control. Fourth is optimization of antimicrobials. Here we talk about optimization of excess, which also includes this AMS program and regulation of antimicrobials, availability and use of it. Fifth one is research and innovation. Because this is one area that you need a lot of research, because we need, many of the antibiotics are losing their effectiveness, so we need to preserve them. But unfortunately, not many new antibiotics, not many new antibiotic classes are coming up. Our pipeline for new antibiotics is running dry. Although there have been improvement recently, WHO in I think 14th June 2024 only they came up with the the number of antibiotics in the pipeline and how many have been put to clinical use. That's a very small number. So which will not help us in solving this problem of this, because we, on one hand, we have a problem of rising drug resistant infection, and on the other hand, the existing ones are losing their effectiveness. So we need to replace this. So we need to find a replacement. So that is why research and innovation is very much needed. New discovery is a very long drawn, time, effort intensive, and pharmaceutical industry for that matter is not interested in developing new antibiotics, because they know within, they will spend years of research, billions of dollars, just to find out that within 6 months to 1 year of marketing, resistance will be developed and this drug again will be abandoned because it is no longer effective. Or even with this effort, the new drug will be reserved for the critical patients, for ICU patients, for which there is a very, if you look at the larger, pharmaceutical industry, will look at the returns on investment. They'll not get enough return on investment on these. So that's why, their interest is more towards the non-communicable disease, diabetes. Once you are a diabetic, you are always a diabetic. Once a hypertensive, you're always, so you'll need these drugs lifelong, so they are more interested. So then now you have to, this is the time that we need to think about how best can we make the diagnosis, how this can be made effectively with the affordable, which is timely. Then we can work on the, we need to work on the measuring this resistance, then surveillance, how can we automate this, so that, because all of this, even surveillance, it's said easier said than done. It involves a lot of effort. You have to have dedicated people doing this. But where are these human resources? In tertiary care, medical colleges, metros, no problem. Maybe you will find this. But when you go down to the district level hospital, CSC level, hardly there are one or two doctors who are working, and they have to do this multitasking. And for them, measuring this antibiotic use, in making these antibiograms, and then surveillance data is an additional burden. So they may will not, and other clinical priorities will take over, so they don't usually get engaged. Even in people like metros, super specialty hospitals, documentation becomes an issue. So we need to find out, use this financing mechanisms, because here the governments need to step in, because we cannot rely only on the private sector. We need to see what are the innovative or new kind of financing, mixed public private partnership mechanisms that can be brought in, which can accelerate this research and innovation. Now AI has again is again, I feel in health it has been quite underutilized. So we should leverage on the potential of AI for diagnostics, for treatment part, uh, for generating these reports. So some of these things, if AI can help, can take care of the challenges, genuine challenges of the people. Now coming to the sixth one, we have added leadership here. Because considering the size of India, it's a diverse country, and each state is like a country for the other matter. So, because you need to have coordination, not within the nation, you need to also coordinate with other countries. So this is one way of building on resources or the databases, learning from others that we can take on. So that's how the national. So with this background, NAP AMR 2017. Now 2 is under progress. The all these strategic priorities are still there. We continue doing, but now emphasis is on how do you implement this at the ground level. Because government can make a policy, they can give you the direction here, but at the ground level, operational level, administrative level, service level, you need to engage more and more actors here, enroll them, so that the ground level implementation happens. So NAP AMR 1 did identify many of these actors. So the NAP 2 is also looking at it, if any one of these was left behind or needs to be incorporated. And then of course the focus of both 1 and 2 has been on One Health. One Health means that the health, human beings, animal sector, environment, this all are interconnected. And so whatever we have learned is going into the NAP 2, because each sector has their own challenges. So looking at their challenge, what needs to be done, what resources are needed, all that is being tried to incorporate this. This time they are having different group discussions with each of these groups, and then taking it forward in the NAP AMR 2.
Your suggestions to make responses to address AMR more people-centric, because very often this comes out as a very, very medicalized thing for the common people, for the patient who is basically at the receiving end. So
Okay. Okay. Before I come to you, this
Yes,
NAP, AMR, I mentioned that strategic priority 6, that
yes.
each state, under that,
Okay.
each
Mm,
state has to come up with their own action plan.
mm.
Now, why is this needed? As you know, it's a diverse country. Each state has its own legislative, administrative, finances, operational service level problems. So they have to contextualize this according to their context. There is no one uniform solution for all the states in India. For example, Kerala was the first one. Till now, only 5 states have had this. 5 or maybe 6 is in the
Which
pipeline.
which
Uh,
are those states, ma'am? If you can just
First one was Kerala,
mm,
second was Madhya Pradesh, third
mm.
was Delhi,
Yes.
then Sikkim, and
Mm.
Andhra Pradesh. These are five.
Okay.
I think I
Okay.
am not sure about Gujarat. I think they were also in the process, or they must be
Okay.
just about
Okay.
to do it.
Mhm.
So, but
Mhm.
considering that there are 28, 29 states
Yes.
in the country, only 5 have come up
Mhm.
over this period. So, one thing in that too, one has to see to it that this is implemented nationwide.
Mhm.
All states should come up with this, because each state has its own problem. For example, Kerala, being the coastal state, aquaculture is a problem. Whereas in Delhi, we import most of the food. We don't have farmlands here, but importing food from other states is a issue for us. So accordingly, we will make our action plan, keeping our challenge here. So each state may also vary in their strengths, laboratory strengths, network strengths. So you have to build according to your context here. Sikkim in the northeast, they have their own issues. So each state should come up with their state action plan. And then after that, even after NAP 2, operationalization of these plans is very important, which gets ignored. How do you operationalize this? Action plan is there, roadmap is there, but how do I implement this? What are the indicators that I need to monitor whether this is working for me or not? So that operationalization has to be, focus should be on NAP 2, that how do we operationalize these state action plans. Then now, coming to your question about how do we make it more people centric. Now,
Yes.
I think when you say people, you mean the public.
Yes. I mean the general public. Yes.
Okay.
Mm.
Yes, definitely. They are the consumers of
Yes.
these. And most of the time when we talk about the stewardship, we are talking about the hospital.
Yes.
And I say, only 20% of the use happens in the hospital. 80% of the antimicrobials are used in communities. If you
Mm.
look at the total, consumption, the proportion, 80% consumption or use happens in communities. So definitely they become a very, very important stakeholder here. Because many a time, even in the hospital setting, if you're talking to the clinician and ask them this question, why do you prescribe antibiotics? Very often than not, you will hear from them that the patients come and demand for it. If I don't give antibiotics, patient will demand for it. Or if I don't give antibiotics, patient will buy over the counter or will start using it on their own. So this is self-medication. They start self-medication with them. So public education, because we need to work on the demand side as well. We are talking to the clinician to optimize their use, but we need to look at the demand side as well. So we need to engage communities. We need to talk to, provide them with information, empower them. So with this requirement, our society has also been very actively working on public education. For 2 consecutive years, we did mass campaigns with school teachers. We covered all school teachers from Delhi state. and we sensitize them to this problem of AMR, because mass campaigns are also very expensive and require a lot of efforts. And also we felt that now they have been sensitized, we must take it far forward. So for last 2 years, we are doing targeted campaigns with school teachers. Now, when I say targeted campaigns, these are 3 months long online campaigns. We enroll teachers. This is voluntary. We send out invites to them. So school teachers on their own register. And for 3 months, we talk about various aspects of this antimicrobial use, infection prevention, AMR, etc. and that. So, and that has generated interest, problem. And we targeted school teachers because we think that they prepare, they are in connection with the students, peers, friends, sibling, so they can influence them. They are in the position to influence. Current curriculum does not cover this aspect of infections in their curriculum. So we supplement this. Now, during these public educations, we found, for them, these antibiotics are like paracetamol. They never knew that this is the problem with the antimicrobial use. Uh, they felt that it's like paracetamol. Whenever they had fever, they took paracetamol, and because the doctor had been prescribing these antibiotics whenever they were sick, and when they are now down again with the similar symptoms, they can take these again on their own. So they did not feel the downside or harm of this practice. So during these sessions, we sensitize them to these aspects. Taking on your point on infection prevention and control. Now, many people in the beginning asked us, what school teachers are going to go do about this. Kitchens are there, toilets are there in the school, and often these school teachers are overlooking the hygiene, sanitation. So vaccination part, the children when they get sick in the school, the standard precautions that they need to take to stop spread. So all these aspects are covered, we covered during these public education programs. And you may call this as a self-appraisal, but I was looking at the feedback. Almost 99% were happy with the information provided, and they found that it was useful to them. It helped them in upgrading their skills, and now they are in a position to tell their friends, family, students, to talk about this problem and more. I think something like this can be done more often and to a bigger scale. Taken to a bigger scale.
And here sensitizing one teacher means you are sensitizing so many pupils who are there in the school or who the teacher is addressing to.
Yeah, because we believe that we need to prepare future generations as well.
Yes,
one is that we need to preserve these antibiotics for future generations.
Yes.
Our generation has had the golden era. There are a lot of antibiotics were available. They were effective. We used them. But looking at the scenario now, I think we must ponder over this. What is it that we are leaving behind for next generations? If the current ones are losing effectiveness, what is it? New ones are not coming. That pipeline is very slow. Current are losing effectiveness. So how are we going to deal with these infections? When this penicillin came in around 1960, the clinicians, the experts said, we need not worry about the infections anymore. But the present day situation scenario is that they are still a very, very significant part of the burden of disease. We have added non-communicable diseases to our burden: diabetes, stroke, heart problem, hypertension. Third is road traffic accidents and all that, and these non-communicable diseases like diabetes, it's a immunocompromised state. These people are more prone to get infections. They need more antibiotics very often. I think we have made this quite complicated now. We should start working on it and start, straightening out some of it, if possible.
Thank you. There is a question from Zafar Irshad from Bangladesh. And Zafar wants to know that what you have spoken about diagnostic stewardship and the challenges there, that should we accelerate deployment of point of care and battery operated molecular testing platforms which can test multiple diseases? And should we focus on that also? And he's giving sorry, just to complete what he said, he gives the example of Bangladesh, where for a disease like TB, WHO recommended molecular diagnostic tests are not available for everyone. Just 20% of TB patients in Bangladesh get molecular tests, and the others get microscopy, and sometimes they are diagnosed incorrectly. So deployment of, again, point of care multi-disease platforms, which are there?
Very good question. Very good question. I think the problem says it all, how complex it is. On one hand, just a minute.
Yes.
This is a very, very important, pertinent question. On one hand, we think that the point of care testing will help in diagnosis and should take care of this. Time for giving reports for most of these testing, TB or molecular, although they are helping us in the diagnosis, but accessibility is one issue, that this is not available. But again, I think I have Dr. Renu Gupta here. She can supplement this. She's working with me on diagnostic stewardship, but that will also not solve all your problems. So we need to look at the resources. Now, going back to the point of care testing, but I think you remember I said it is a more of a human behavioral problem. COVID-19, first wave, we did not have the tests. Second phase, we had these rapid diagnostics available. And within 15 minutes, anyone would know whether they are COVID positive or COVID negative. But what happened to the antibiotic use? Still, many people, were prescribed or took on their own these antibiotics. So antimicrobial use, that's why it becomes more and more complex here. So you have to take the right decision. While TB, I agree, fully agree, you need to have these tests available. These tests have revolutionized the TB treatment because now the diagnosis is quicker, the resistance pattern, so you can start with the targeted anti-tubercular therapy right without any waste of time. Certainly, this helps. But in routine clinical practice, Renu, are you there? Could you come in?
Yes, ma'am.
Yeah.
Yes, ma'am. Can I pitch in, ma'am?
Yeah, sure.
Yeah. This question is very pertinent. This problem is not only in Bangladesh. We in India are also facing the same problem. There is a paradox everywhere. On one side, we are struggling with the accessibility. We do not have access to the basic test. Yeah. As for tuberculosis, this multiplex PCR, or even WHO is advocating the use of the PCR, and it is a very good gold standard test and very much needed test because of the resistance it can pick up. But it is not available uniformly. And so this is the compromise. So this is the need of the hour to practice diagnostic stewardship. If we conserve our healthcare resources and use the test judiciously, for those patients where it is needed, we are trying to improve the accessibility, but it is just not a miracle. It cannot be made available just like that. So sometimes you have to balance out. Everything is about balancing. In some things, this PCR is a very good test, but not for all the diseases. Like many a times you must have seen, like for viral diarrhea, which are self-limiting diarrhea, multiplex PCR is done. So we have to conserve our resources and use them properly. If we are not doing multiplex PCR where the disease is self-limiting, we may divert our resources to such a big problem like TB. This problem every country is facing. We are also facing this in India. WHO has said that move to the gene expert. And regarding, so this is the issue.
Yes. Sorry, can I interrupt there, ma'am? Yes,
Yes.
a gene expert is there, but we have our own indigenous TrueNat machine, which is actually point of care test and which can be deployed just very, very close at the PHC level. And is a battery operated and does not require a lab or all that paraphernalia. So I think and it is indigenously produced and it is WHO recommended. It's the only point of care test for TB which is recommended by WHO, and that platform can test for several other diseases. Perhaps it is underutilized that way also.
Yeah, true. I think you've been doing a lot of program on TV, you know
Yes,
about this.
That is absolutely true. But in Bangladesh, still this TrueNet is not available, or any other platform is not available. They are having this accessibility issue. 80% of the population is still being tested by microscopy.
Yes, you're right there. You're
They
very
may
right.
be shifting, and we are all trying to shift toward molecular because we know it is a very good diagnostic test.
But cost and accessibilities are the issues that we need to work on this. And also many times in general, I'm just talking about in general, the recommendations or the standards that we do, we need to contextualize this also to some extent. If not, you know, for us, if gram stain was the thing, you know, other non-TB infections, I think gram stain, you know, we're trying to bring this back as a bedside procedure, quick procedure, so that you can immediately narrow down, you know, what you are dealing with. So all these things need to be contextualized as well.
Yes, rightly so. So I think we have overshot the time. Any more questions from the audience, or anybody wants to make any comments, or there are some in the chat. So Zafar Irshad says that in Bangladesh, TrueNat is deployed and as like a lab on wheels. And there is some link also given for that. And Karthik Shah says that robust mechanism is there for AMR test, but it is not available due to cost to every patient. TrueNat and CBNAT machines are not available across the facilities. So I think we need to boost up our own indigenous platforms, which are such robust and good, and they are cheaper also. In many respects, the overall cost is much less. Maintenance
over the
cost.
Period, over the period, cost has gone down.
Yes,
we need to work on the scalability of these tests.
Exactly. So many thanks, Dr. Sharma, for such insightful sharing of your wealth of knowledge and for your meaningful suggestions on how to combat antimicrobial resistance. Friends, we were listening to Dr. Sangeeta Sharma, Professor and Head, Department of Neuropsychopharmacology, Institute of Human Behavior and Allied Sciences, Delhi, and President of Delhi Society for Promotion of Rational Use of Drugs. Thank you. Stay healthy till we meet again. Thank you very much.
Thank you, Shobhaji and CNS, for arranging this platform for interaction. I think I was also it was quite satisfying interacting with you.
Thank you. So were we. Yes, thank you.
Okay, just to, I think AMR, we have included all these aspects in our recent edition on standard treatment guidelines. These are comprehensive, ready reckoner type point of care resource for the clinicians for management of around 350 priority diseases which we come across in various disciplines. I think it would be good if you could go through this. And we've given pearls for prescribing antibiotics along with the, when we are discussing the management of these diseases. So it could be one of the good resources, time-tested resources for managing infections and other diseases here.
Okay. Thank you. Thank you very much. Thank you.